Hey, Dr. G here, coming to you from the bright Arizona sun. So I'm getting my morning sun like I recommend my health coaching clients and patients get on a regular basis. And I'm going to talk about an article I saw on JAMA Network that was published in June of this year. And this was an interesting article because it was looking at angina. So angina is chest pain that people have when their arteries to their heart aren't providing sufficient oxygen, and so the lack of oxygen creates pain. And chest pain is something that, of course, is important. You get chest pain with a heart attack, the leading cause of death. Millions upon millions of people have heart disease, so this is a really common disease. It was not so common in the past. In fact, it's pretty rare in hunter-gatherers. There's still some hunter-gatherer groups left in the world. And those groups have low heart disease, but people that live in the cities, and I believe because we change our environment, it's now the leading cause of death, and it's really common. So this article talked about a study where they looked at patients with heart disease, coronary artery disease, and their symptoms. And so angina, which is chest pain, is a symptom of heart disease. And then there's stable angina and unstable angina. Unstable is where it could happen at rest or it's out of control. And stable is it happens in a predictable fashion. So they were looking at patients and their reported chest pain. And what they found was there was a difference, a significant difference between the chest pain that the cardiologist put in the chart saying what the patient has versus what the patient said. So this is interesting. So it was much more common. It was actually a 35% increase in chest pain. So 35% of these patients reported in the last 4 weeks that they didn't have chest pain. Yet the cardiologist documented in the chart that they had moderate to severe chest pain. So that's pretty interesting. Okay, what does chest pain lead to? Well, it leads to percutaneous imaging, where they put a catheter up your groin or through your arm and put that catheter in the heart, and they can then image the arteries and see where they're narrowed or blocked. And that often results in stenting. They put a stent to prop open that lumen that's narrowed. And so when you have moderate to severe chest pain, it's much more likely that the patient is going to accept, yeah, I need to have this invasive procedure. Plus, it's more likely to get covered by the insurance. So the cardiologists, fudge it. The patients actually said they haven't had chest pain in 4 weeks. The cardiologist describes it as moderate to severe, okay? And think about when you see a cardiologist and they find out that your artery is blocked, and they make it, they do the testing like, hey, let's do a stress test tomorrow. You're having some shortness of breath. Let's do a stress test tomorrow. And then if that's abnormal, oh, well, this afternoon we better image your artery. So they're acting like it's a life and death thing to get imaged. And that makes sense. I mean, it's just common sense. Hey, your artery's blocked. You're at risk of dying right away. You could have a heart attack any minute. So we rush. But one of the things that cardiologists hopefully don't tell you when you go for that percutaneous imaging that's going to lead to a stent, hopefully they don't tell you this is going to save your life. Because luckily there are people out there that are going, hey, we do this, but we should study it. We should make sure this makes a difference. It's invasive, it's expensive. Of course, the expensive part is the part driving the cardiologist. He's got to make a living or she's got to make a living. And so these procedures pay them a lot more than their regular office visits. So they're highly incentivized to do these procedures. So they kind of fudge the symptoms, make them more severe than they actually are. And, you know, I didn't make this up. I always thought this, and all my years of practicing, I thought, well, they rush you, they make it sound urgent so that you're more likely to just, you know, sign the consent form and just do it because you go, well, they must know what they're doing. They're specialists, they're cardiologists. But they did a trial of comparing where it's blinded and controlled experiment where they randomly select, like one person gets the PCI, the percutaneous imaging, and the other person doesn't. They take, you know, the drugs, nitroglycerin or whatever they give you for your chest pain, they give you the drugs instead, and they compare those two groups. And when your angina is stable, in other words, it's predictable, or you just have a blocked artery but you're not having symptoms, the stenting procedure does not give you one more minute of life. The mortality is the same, whether you get a stent or not. So, is there a reason to do a stent? Now, if you're having a heart attack, I can see the stent. You're you know, rush to the hospital, 911, and because you're having crushing chest pain, and they see an infarct, meaning the cells in your muscle cells and endothelial cells are actually dying, and they determine that by lab tests, and also the EKG can show you if heart muscle looks like it's dying, and then opening the artery can save some tissue. But if you're doing it for stable angina, it shows that it doesn't. Now, they do say, oh, but your quality of life will be better. I'm really suspect of that as well, because who decides that your quality of life is better after the procedure? The cardiologist. So if you know, saying you're having a little chest pain prior to the procedure, oh yeah, moderate to severe, you know, let's, you know, get the stent in there, get your artery open back up. Then after the procedure, so many times people still have the same pains that they were having before the procedure. But after the procedure, your cardiologist has seen the perfusion in your heart is absolutely normal. You're saying, yeah, I got a funny feeling in my chest here. And goes, oh yeah, that's just, you know, chest wall pain, atypical pain. You don't have any angina anymore. And a little pain is angina prior to the procedure, and then afterwards, after they know your arteries are opened up, well, it couldn't be that. It's, you know, your chest wall, atypical pain, not angina. So that's, you know, quality of life. Well, he's not having angina anymore. Even though you're still having chest pain, they don't classify it as that because they know your arteries are now open because they saw it. They saw your arteries open, so they are going to call that pain something else. So your quality of life has improved. So in reality, your quality of life did not improve. So as you can guess, I'm not a fan of these procedures, and I'm not a fan of them because we are completely ignoring the cause. Okay, there's a lot of causes. They mostly have to do with our environment. And that's why hunter-gatherers, there's a tribe in South America that has almost no heart disease. And they don't have a special diet, or they don't exercise differently, but they have a primitive lifestyle. They're not exposed to the electromagnetic fields that we are. They're not exposed to the artificial light that we are. They're barefoot on the earth, and they get a lot of sun exposure. And we found out recently that circadian mechanisms are directly related to heart disease. In other words, if you're not getting the morning sun in your eyes like I'm doing right now, then you don't stimulate your master clock in your brain, which stimulates gene expression to produce a protein called PER2. And PER2 is critically important for the endothelial function, which is the lining of the arteries inside our heart. They leak without adequate PER2. PER2 is stimulated by light exposure in your eyes. They've proven that in animals and humans, yet cardiologists don't talk about that. So you got to look at the cardiologist as someone that has their own agenda. Now, they save lives, no doubt, but they're human, like all of us. They need to make a living. They've been taught how to do a certain procedure that pays them pretty well. So they are incentivized to do that. But you as an individual, chances are very good that is not going to have any benefit for you, because the randomized studies show that. It's not like I'm making it up. So it's good that science does studies of things that are just common sense says, hey, open your arteries. It's got to be good for you. It's got to save lives. Doesn't in the case of stable angina or coronary disease where you're not having symptoms. Okay, Dr. G here. Be sure to get your circadian mechanisms humming, because it's not only the heart, it's everything else in our physiology is controlled by this. Every cell has circadian clocks, which is a process of gene expression and a protein that has an effect on how we work. Okay, good talking to you. See ya.